Guys, I'm here with Dr. Sean Behnam, Santa Monica, California.
You're welcome.
Thank you, Dr. Sean. I have this on because I was looking at him perform surgery on a patient who's a class 6, maybe class 5. His sides are pretty high, but his crown does dip down a little bit. He's had surgery for 2 days now?
2 days.
The second day.
Second day today, yeah.
Scheduled to get 6,000 grafts?
Yeah, he passed this 6,000. I think he got 6,200 grafts.
6,200 grafts. So
we have to see the exact number.
That's pretty big. And I wanted to talk to Dr. Sean Behnam here. You guys know how much of a proponent I've been for Verteporfin. I think it's something that could really change the hair transplant industry. I think that there's not enough research and more research needs to be done. Since I'm local here, I've offered my services to film a patient. If a patient agrees to have a Verteporfin trial, film it, update you guys monthly. So, Dr. Sean, are you willing to do a Verteporfin trial?
100%. And I have patients who are willing to do it. Maybe the whole case. Just using Verteporfin.
That's great. And you told me you spoke to an eye doctor about, the potential side effects of Verteporfin.
Yes, so I think as long as we dilute it enough, I think it would be just fine. I think that's part of the research and experiment.
Yeah.
And these are experimental. And this is how the whole field grows. So I know there are a couple of guys that are doing on small scale.
Mm-hmm.
But I think it's just easier when you punch out 10 grafts and add a high concentration of Verteporfin. I think yes. But what happens on a bigger scale when you're doing 2,000 or 3,000 grafts and you have to dilute it? Will it give you the same results? I think we could really have a patient who's, wants it and is dedicated to doing it, and you can figure it out. See,
would you be willing? Because I have a group chat with Dr. Bazanga, Dr. Barghouti, and Dr. Ted Milne, who's in the UK. They're all in agreement to do a trial.
Yeah.
They all have protocols. I thought that it would be in the best interest of everybody if surgeons could kind of come together and get like a protocol. So it's streamlined.
And that's when things work best anyways, when there's an established protocol based on everybody's experience. So no one person is reinventing the wheel. Benefits patients the most.
Yeah, less variables and stuff like that. So great. I will include you in the group
100%.
chat. Guys, I'm also going to give him the link to get the Verteporfin. Not the name brand, because that one's very, very hard to get and you have to jump through hoops. But there's a research grade, which is being used by Dr. Barghouti already. So all the clinical data that we have on it so far has been used with this research grade. And I'll give you the link.
100%.
So that's super exciting news.
I'm very excited.
Yeah, I'm excited as well. What's changed in the last 10 years?
It was mainly strip. I think it was 90% strip. Now strip is less than 1%.
Wow.
I mean, maybe one strip every 2 to 3 months.
Wow.
Now everything is FU. And I think what's really changed over the past many years is, this is a field that continuously changes every 6 months.
Yeah.
And a lot of new devices has changed, has been upgraded since 10 years ago. And a lot of experience. And now we're doing larger cases. For our numbing is better, our punch size is smaller, our philosophy of extraction, it has improved. Now we're able to incorporate, better extraction techniques that you could extract large volume of grafts, and at the same time, when the hair goes out, it gives the illusion that not as many were extracted just because the pattern of extraction. Nothing's done straight lines, things are in zigzag patterns. And also anesthesia has gotten better, and anesthesia techniques has become better. We now use more nerve blocks as opposed to just numbing, one individual square centimeter. Our placing has gotten better. Now we use all implanters. And so everything has continuously changed. We're continuously making changes. And 10 years ago by now, it's like, a car that, keeps getting better.
I think every surgeon that, is out there, if you ask them if their practice has improved in 10 years? Everyone's going to say yes, absolutely. Things have changed drastically over 10 years. A lot of the doctors that used to be FUT only or strip only now are only doing mostly FUE. So I'm happy to hear that. I witnessed you in surgery today, and I saw, a lot of grafts were harvested and a lot of grafts were placed. So I'm happy to see that. A big difference from 10 years ago. I was a Norwood 6 and I only got I think 1,800 grafts or something like that over a large surface area, which is not going to give you that same result that 6,000 grafts would give you. So that's a big difference.
That's a big difference. And I think the quality of the grafts are better and the placing is better and the teams are better. Now you can have a better surgical assistant team. I just have 7 people assisting me.
Wow.
So
yeah, it's a big team.
It's a big team. So that
back then it was 2. It was 2, yeah.
A lot of things have changed over the past time. It's continuously changing. So, and I think getting back to doctors, I think there's some doctors who don't like the concept of change. And there's some people that really never move past FUT. But I like change. And even for, and one of the, I think, good things about practicing LA is that you just don't have one specific ethnicity.
Oh, yeah.
I mean, one day we have Korean, one where today we have Middle Eastern who has a thick, coarse, curly hair. And another day, you have an Asian or an African American. I mean, I do a lot of ethnic African American FUE woman.
Wow. Tell me about that. What's the difference between, let's say, straight hair? I would consider my hair probably medium thick, but it's relatively straight. Compared to somebody with afro hair, what's the difference?
I think just the technique. The technique is really different. You just have to. It's experience. You have to keep doing it. Look, I remember at one point I only did 300 grafts in 2014-15.
Yeah,
300 grafts. Just in one day, just because the techniques is hard. I think once you get the technique down, and every person is different, then you can get large volume, 2,000. I think for ethnic curly hair, 2,000 grafts a day is a very good number. Just because, the skin is harder, so it's, the whole philosophy is completely different.
What would you say is your transection rate for, Afro and patients?
So my staff calculates transaction rate, and if I'm transacting, we stop and we change the angles. I like to keep my transaction rate about 2%. I mean, today's case, we got 3,200 grafts, and transaction rate was about 150 to 200 grafts.
Wow.
So it's minimal.
Yeah.
So we want to keep it minimal. And we take photos of everything. So we take photos of all the grafts for all the patients. In fact, we take almost 100 photos and videos throughout the whole day. So we show how the extraction was done, how the grafts look like, how the placing is, how the site creation is. Those are very important. So we compare the beard hair and the scalp hair, the diameter, the length. All these count. And, I think it's the fact that I take so many photos, and patients send me so many photos, that I've been able to make so many changes over the past many years. Because we're doing this for get good results, to make patients happy.
So I've been asking this a lot because obviously AI it's going to become the future. It is the future. The future AI is going to be changing. It's sort of like when the iPhone came out and we kind of were on the cusp of seeing how life was going to be different. I feel like that's AI. It's still in the very beginning stages, but I mean, in 10 years from now, the AI is going to be insane. How do you see AI playing a role in hair transplant surgery?
Amazingly, I recently had a patient that worked for OpenAI, and he told me this is very tedious. However, as you know, we are working on a certain robot that has AI incorporated in it. Okay. And I think over the next many years, the extraction and the placing process will be, semi-automated.
Wow, really?
Now, these things take time. Machine learning is not easy, but it's slowly AI will be incorporated into extraction of the hair follicles, site creation, pattern recognition, and placing.
But that's probably maybe a long time from now. I mean, we have the artist, right, which
Yes.
also controversial, but most surgeons agree that it's not.
I like to do the work myself, and for many reasons. I like to be present during the procedure, and I don't like to leave it to any other staff members, no matter how good they are, because I really understand the skin, the hair. So we just have to really wait and see to see how these machines and robotics play out over the next 10 years.
Yeah, I did a podcast with Dr. Patella. I was in Brazil, and he showed me the thing he developed, the scalp scan. And what I feel is going to be so amazing with this is that you scan the donor area and it automatically can measure the hair shaft diameter. It measures all the hair you have, how many grafts can be extracted. So if you want to extract up to 50% of the donor, they'll tell you how many grafts there are, and 50% will tell you precisely how many grafts this patient has. And I mean, you can extrapolate that out over a lifetime, so you can have like the patient's lifetime grafts. Like if this patient's
that's what we do. So during the consultation, right? And my consultations, I do myself takes a whole hour. I calculate estimate total number of grafts. And I calculate if I remove 40 or 50% of the grafts from the back of the scalp, how many grafts we could get. And it's actually very consistent. Right, so for this patient, we got about 5,700 grafts from the donor area, and he has about 12,000. So it's almost 45 to 50%.
So how many does he have left after this?
So he's going to have about 5,500 to 6,000 grafts left. Yes.
But to extract, like if you needed further surgeries down the line, he would have possibly.
Well, you just have to see. I mean, they have to use a lot more beard hair and a lot of body hair. Now, in the United States, I do at least beard at least 2 to 3 times a week. Maybe that's 4, 5, 6, 700 from the beard area. And I think over the next few years, I think people are very conscious of how it looks on the face here.
It doesn't scar.
It does not scar. But I think over the next few years, as more people need, we get a lot of beard and chest hair. We're going to be doing a case 4,000 grafts, only beard and chest. This guy doesn't have any donor hair at all. He's weak.
Yeah. I've seen patients in real life who've had this almost all removed. There's a guy on who's a value contributor on the forum named Adrian, and he had mostly, I don't know, maybe like 5,000 from his beard.
That's great.
And he shaves. You can't see anything. I mean, the face heals so incredibly well. Way better than the scalp. That's something that I think, should be studied. I know Dr. Umar here is a pioneer in that. But it's nice to see. How many grafts do you usually do in the beard? Like
about 700.
About 700?
It's a very good size, nice amount.
Yeah.
Yeah. And these zero scarring. I never had a complaint.
What's the maximum you've done FUE in on one patient? Like how many grafts?
About 8,000, 9,000.
8,000. That's a pretty good number.
That's good, considering body hair and everything. This guy is 6,000. You just have to see how he heals and what degree of hair loss will we have. But yeah, 8,000-9,000 seems to be a good number.
Yeah, I mean, I feel like the biggest thing for donor hair is that you don't know how much hair is in the telogen phase is incredible. I had almost all this hair here removed.
Yeah.
And a few days after the procedure, I started getting a whole bunch of more hairs that were just in the telogen phase. They were in the dormant phase.
Yeah.
The same thing happens in the donor, so
it sure does. I mean, and as I mentioned, the pattern of extraction is important because once the hair regrows back, right, the shaved ones, you could go through it again, and as long as you use a very nice, consistent pattern, you'd be surprised you could do it more.
Yeah,
it's all relative, and I go actually very low in the donor area, almost to the nape of this of the scalp. So I even everything out, because once it's evened out, then it looks very consistent. And once things are done on zigzag patterns, even the edges, it blends nicely. You don't have that sharp, the contrast where the grass will remove, where the grass will not remove.
That's the biggest thing.
And I see that a lot. And I see that a lot when doctors try to go from the center, best area. But you really have to spin it out and even get from the areas that, maybe the future is going to tell that. But this is an art. The donor area is an art as well, and the way it's extracted is an art. And if it's done consistently, we're going to see with this patient. If you come back again, I could probably do another few thousand grafts.
Yeah, no, I agree with you 100%. I feel like, a lot of people are talking about Dr. Zarev. They don't believe it. They don't believe, and I've talked to him. I did a podcast with him. He's shown me photos. There's a lot of patients on the forum now. He uses the entire donor.
You have to use the entire
harvest everything, and even in the borders, he will transplant into the borders so that there's no abrupt. Because a big thing is you extract, but you leave like maybe about a half an inch of donor that's untouched, and you harvest all through here, and then this little border here is not transplanted, and so when it grows out, you see a border of thick hair, you see a border of miniaturized hair, and a border of hair that's been harvested, and it's not aesthetically pleasing.
Especially when you wear it short. So that's why I love these bigger cases, because then you really go through one side really nicely, and then you go through the other side. And I think what really prevents a lot of docs from doing it is the anesthesia. I think once you pass, you really learn very good anesthesia techniques, because it takes a few hours of punching, of extraction. Then it really takes your time and focus and blend everything in. Blending is very important.
Yeah. That's one of the biggest things. I know before, some surgeons would do only one side. They would only harvest one side of the donor, leave the other side.
That's the worst. Even when we do 2,000 grafts or 3,000 grafts one day, I distribute everything out. It all depends on, again, knowing how many grafts somebody has and what pattern of extract. Are going to extract one every 4 grafts, one every 5 grafts, and it really requires a good consultation, even on the day of the procedure, where we take lots of photos, where we analyze the number of grafts he has, and so you don't over extract one side or another side.
So when you do your consultations, do you look at the donor with like loops?
100%. Loops, magnifier. We do extraction. We calculate the estimated donor area of the grafts. So see, I used to have sheets where, anyways, I have sheets where we actually identify the number of grafts per square centimeter on the right side, left side, nape of the neck on the top. And that's important because your extraction constantly, the amount that you extract may be less from the bottom and more on the top. So it creates a more consistent flow after the hair grows. Mm-hmm. And I see a lot of patients where they had the procedure done elsewhere, and it's a straight line and over harvest on the top, not harvest on the bottom, and you have to blend it in.
Yeah, no, that's a big...
And that's what really takes a long time. I mean, the extraction takes a long time because I have to step back and say, okay, how are we extracting? And what's the pattern? And where are we extracting from what regions?
Now, what's the biggest problem with the hair transplant industry that you would say?
I think the number one problem with the hair transplant industry is that doctors are not doing the work. And I think doctors just want to get in, just pass the patients along to some staff and technician, and just focus more on marketing and have 2, 3, 5 clinics. I think you really have to be focused. Just one case a day, just one clinic, do the consultation yourself, do the extractions yourself, do this, be really involved in every aspect of the entire procedure, because there's a lot that goes on and a lot that you really have to understand. That's how you make changes. If not, you don't know what's really going on, and patients end up not having great results. So despite the fact that I am involved in every case, we take 100 photos per case throughout the whole day. And I'll review all of that. And, every person is different. Some patients have tough skin, soft skin.
Yeah.
And you have to be there to monitor to make sure this happens.
What's your rebuttal for a lot of surgeons will say that the reason why FUT or strip was superior was because they could sliver the grafts and have more fatty tissue, and that, FUE grafts are skeletonized and there's not enough fatty tissue for it to grow.
Look, you need a certain amount of fatty tissue for it, or tissue for it to grow. You don't need too much. Too much is not good, right? I mean, I think with the strip, the reason you need so much fatty tissue is because use of forceps goes along with strip. So very few people use implanters with strips.
Yeah.
I think I'm one of the only one that with African Americans that want FUT, because some of them want, I use implanters. But with FUE, as long as the staff does not touch the root itself, you really don't need a lot of tissue. And a lot of patients come back, again, in the United States, a lot of doctors still do FUT.
Yeah.
Patients come and say, this doctor said FUT is superior. Unfortunately, it's not true. I mean, 99% of all my cases are FUE.
And you were a strip surgeon.
Yeah,
10 years ago, you were primarily...
I think this is, I didn't at that time, I felt that FUE is better, less pain, and no minimal linear, actually no linear scar, and, and you could get more grafts, you could get a better sense of completion. Look, this guy got 6,000 grafts. You can't even do that with FUT.
Yeah.
Not in one section.
Yeah, I mean, with FUT, there was only Hassan and Wong were doing those huge steps.
But I don't think I think they're now almost FUE.
Now I interviewed Dr. Hassan 2 years ago, and he said, my FUE is better than FUT.
I agree.
So that's crazy. I mean, there's really only a few surgeons that are now still saying that FUT is superior. I feel like there's enough information out there now and the techniques evolved enough that FUE is just as good. I mean,
I do not remember the last case that converted an FUE to a FUT.
Yeah.
I just don't remember the last case that actually ever happened.
I will say that FUT will always probably have its place, and some patients are, good candidates for FUT over FUE. That will be the case. But the notion of a decade ago, especially here in the US, where everyone was saying, FUE just doesn't grow good, and too much transection.
I still hear it. That's why we take photos of all the grafts. And I show the patients. I mean, this is very, very important. So, FUE is even going to get even better. Now, I think as we incorporate more body hair into it, I think over the next few years, we're just going to see more and more body hair, chest and beard incorporated into these cases.
I feel like over the next few years, you're going to see more grafts being harvested from the donor area. Because there's Zarev, Patella. I mean, these guys are doing on a regular basis patients 7,000, 8,000, 9,000. Zarev does up to the guy on the farm almost 12,000 grafts, all from scalp. And that he said it's because of his punch, and he can extract up to 60% of the donor without creating an aesthetic.
I think once you get down to a certain low punch, I think you could do it.
Yeah.
So, it's just that a lot of manufacturers don't manufacture punches so small. I mean, I had, we did a case where we used 0.55 grafts on a patient, and, he only had 4,500 grafts in the back of the scalp total. We wanted to extract it so far, 5,700, that his donor still looks really good.
Yeah. So imagine, in the next 10 years, I would imagine that more and more patients are going to be able to get
more grafts.
That's
from technology and experience and punches.
Yeah, and that's where I think AI is going to play a role.
Yes, AI will 100%.
I think that's where AI will play a role, because it will be able to pinpoint exactly with definitive data. This patient has this many grafts available before, it will start looking depleted. So the surgeon will be able to be like, okay, we've done 5,700 grafts. According to this, data, you have another 3,000 or 4,000 grafts that can be done.
Yeah, we do that right now with calculation.
Yeah.